A warm good evening to everyone. I'm Dr. Smitha KS, Assistant Professor from Bangalore Medical College and Research Institute. So let us look into pharmacological considerations in obesity. Obesity has become a worldwide epidemic, with India being in greener zone with a prevalence rate of 5.21%. Karnataka is in orange zone with 7.2% in India. And the percentage of these overweight and obese persons coming for surgeries, either bariatric or for other surgical reasons, is increasing. To anesthetize these obese people, a thorough understanding of anesthetic considerations and anesthetic pharmacological considerations are important. Anesthetic considerations will be dealt by Dr. Bhargavi, and I will be dealing with anesthetic pharmacological considerations in obese. Let's start with a scenario. There are two patients, patient A and B. Patient A weighs 60 kgs and B weighs 120 kgs. They are of the same height. Since all the drugs are given as per manufacturer recommended dose based upon per kg total body weight, so if we give propofol 1.5 mg per kg total body weight, patient A will receive 90 mg of propofol, whereas patient B will receive 180 mg of propofol, which is highly impractical and causes overdosing. So to resolve this problem, the factors to be considered are the changes in the body composition of obese, physiological changes associated with obesity, the physical properties of the drug used, and the type of the weighing scale known as dosing scalars. The changes in the body composition of obese compared to normal person are, in normal person, the lean body mass consists of cellular components with intracellular fluid, extracellular fluid, minerals, and the muscular mass, which usually constitutes from 70 to 90% of the total body weight, and fat constitutes of around 20%. So that the lean fat ratio is 4:1. Whereas in obese individual, there is increase in the lean mass and also there is increase in the fat tissue. But however, the proportion of the increase in the fat mass is more than that of the lean mass. And the lean mass is increased in obese because the muscle mass also increases to support the extra fat tissue, and the blood volume is increased due to increased cardiac output due to increased metabolic demand by the lean body mass because it is metabolically active, whereas fat is metabolically inactive, especially the visceral or the omental fat when compared to subcutaneous fat. Coming to the physiological changes in obesity, since the metabolic demand is increased by the lean body mass, the cardiac output is increased. This increases the volume of distribution of the drugs. And in liver, the blood flow is increased. The metabolic pathway cytochrome 3A4 is decreased. And other phase 2 reactions are increased. So this increases the hepatic clearance of the drugs. With respect to the renals, the renal blood flow and the GFR is initially increased, later it decreases. This also increases the renal clearance of the drugs. With respect to respiratory system, the lung compliance is decreased, functional residual capacity is decreased, and then there will be fatty infiltration around the oropharynx. And along with obstructive sleep apnea and carbon dioxide retention in obese, this alters the pharmacodynamics. Protein binding, the serum albumin and the protein binding remains unaltered, whereas the serum alpha-1 acid glycoprotein is increased. This increases the binding of the basic drugs, that is the local anesthetics, hence their requirement increases. Gastric emptying and gut permeability increases so that the bioavailability of oral drugs is decreased. And then there is a chronic low-grade inflammation in obesity. This is mainly because of the visceral or the omental fat, which is metabolically inactive. This leads to release of inflammatory cytokines like tumor necrosis factor alpha, interleukin 6 and interleukin 8 beta and others. Increase in the visceral or the omental fat increases the abdominal circumference, and the inflammatory cytokines increase the insulin resistance, causing type 2 diabetes. They cause dyslipidemia, increase in the triglycerides and decrease in the HDL, and atherosclerosis-induced hypertension, all these constituting metabolic syndrome. In liver, they cause non-alcoholic steatohepatitis, non-alcoholic fatty liver disease, cirrhosis, and cancer, also causing renal hyperperfusion and filtration and subsequently renal failure. The main pathophysiological mechanism affecting the pharmacokinetics in obesity are the cardiac output is increased due to increase in the lean mass, which is metabolically active compared to that of the adipose tissue. Hence, blood flow is more to the lean tissues than the fat. This increases the volume of distribution. However, with respect to clearance, initially due to increase in the cardiac output to lean mass, there is increase in the blood flow to liver and kidneys, increasing the clearance of the drugs. However, this increased clearance is offset later by the adipose tissue induced inflammatory, oxidative stress and atherosclerotic damage to liver and renals, decreasing the clearance. Coming to the physical properties of the drugs, the first one being the lipophilicity. So more lipid soluble drugs tend to accumulate in the adipose tissue, making clearance difficult in obese. Ionization, more the hydrophilicity of the drug and lesser lipid solubility. Tissue solubility, the plasma concentration of the drug determines its pharmacodynamics. Protein binding, the proteins, albumin and alpha-1 acid glycoprotein binding is unaltered in obesity. In normal individual, the total body weight is almost similar to the lean body weight or the ideal body weight. However, in the obese individual, this ratio, the lean to total body weight ratio is less. So hence, if we give drugs according to the total body weight, then it will lead to overdose. However, if we give drugs according to the lean body weight, it might lead to subtherapeutic doses. So hence, we have to choose an appropriate dosing scale other than the total body weight, which are the lean body weight. It's the difference between the total body weight and the fat mass. The increase in the lean body mass correlates well with the increase in the cardiac output and the drug clearance rates in obese, suggesting lean body weight to be ideal for drug dosing. Given by this formula. Ideal body weight is described as associated with maximum life expectancy for a given height. When before BMI was used, obesity was considered as 20% more than that of the ideal body weight. It considers only the height and gender. It is given by this formula. Next is the corrected or the adjusted body weight. It uses the ideal body weight and to a varying degree of excess body weight, which must be corrected by a correcting factor depending upon the physical property of the drug. It is used to scale propofol doses with a correcting factor of 0.4, given by this formula. The fat-free mass, this considers muscles, bones, vital organs, and extracellular fluid. Unlike the lean body weight, it excludes lipid cell membranes and central nervous system. It is derived from wide range of unbiased body measurements. Hence, it is useful in morbidly obese, unlike the lean body weight, which is given by this formula. Next is the normal fat mass. It's an extension of the adjusted body weight and the predicted normal weight. It incorporates an estimate of fat-free mass plus a variable percentage of the estimated fat mass, given by this formula. So if we compare between the dosing scalars, so considering two patients, one of 68 kgs and one other is in 185 kgs, and they both are of the same height, 6 feet, the total body weight remains the same as their weight. However, the ideal body weight will be the same in both of them, 72 because it only considers the height. Corrected body weight will be 70 kgs in a 68 kg patient and 117 kgs in a 185 kg patient. Lean body mass will be 56 in a 68 kg patient and 62 in a 185 kg patient. This is the graphical representation of the comparison of all the dosing scales. As can be seen, all the dosing scales are lesser than the total body weight. Ideal body weight remains the same throughout the increase in the weight because it considers only the height. Whereas the lean body weight, after the weight of 127 kgs, it starts to decrease because there will be decrease in the muscle mass and the lean mass. There is another entity called as allometric scaling. The growth of living beings from single cell organisms to obese humans and elephants can be described using allometric relationships. Different organisms' characteristics and bodily functions can be scaled to body size by an exponential relationship to the power of a multiple of 1/4. Used to extrapolate the differences in the pharmacokinetic and dynamics between individuals with different body sizes. It's the standard in pharmacokinetic research, including that of obesity. So in general, the study of pharmacology of the drug can be done under two headings: pharmacokinetics, what body does to the drug, and pharmacodynamics, what drug does to the body. Pharmacokinetics consists of absorption either through oral, IV, IM, or subcutaneous, distribution, that is the volume of distribution, and clearance includes hepatic metabolism and the renal elimination. When the drug is administered, the drug enters the central compartment, that is usually the plasma, and a proportion of it rapidly equilibrates to the vessel-rich organ, that is cardia or the central nervous system, and slowly to the vessel-poor organs, that is the fat. And a constant amount of the drug is cleared from the plasma through liver and kidney. And the amount of the drug that is present in the effect site or the plasma concentration determines the pharmacodynamics, that is the clinical effect. The pathophysiological changes in obesity alter the pharmacokinetics and the dynamics of the drugs. Volume of distribution determines the loading dose. In obesity, the cardiac output is increased to lean body mass and decreased to fat, and protein binding is unaltered. Hence, both hydrophilic and lipophilic drugs are to be based upon lean body weight. Whereas the clearance determines the maintenance dose. The clearance of the drugs is through hepatic, renal, or sometimes through rapid clearance through non-specific esterases. Hence, total body weight or lean body weight can be used to calculate the dose depending upon the drug. Coming to the pharmacodynamics, most of the IV agents and the opioids, they cause depression of the central nervous system, cardiovascular system, and respiratory system. And along with that, comorbidities present in the obesity, that is atherosclerosis, type 2 diabetes, hypertension, airway redundancy, obstructive sleep apnea, carbon dioxide retention, and decreased lung compliance. All these together decrease the therapeutic index of the drugs. Hence, fine tuning of the dosage is required to avoid overdosage and to get the desired clinical effect. So with this basic outline of the pathophysiological changes in obesity, so let us study the individual drugs. Propofol. It's a hypnotic, it's a CNS respiratory stimulant depressant. It is highly lipophilic, but with decreased blood flow to adipose tissue than the lean mass. Lean body weight dosing is ideal for the induction. Whereas the steady state volume and the clearance of propofol increase linearly with the total body weight. Hence, total body weight is ideal for maintenance dosing or TIVA for propofol. Thiopentone, it is also an hypnotic. It's also a CNS respiratory and CVS depressant. Also being highly lipophilic, and due to decreased cardiac output to the fat and lean, but increased to the lean mass, the drug distributes mainly to the lean body. Hence, lean body weight is ideal for induction dosing. However, clearance has increased twofold in obese due to increase in hepatic and renal blood flow. Hence, total body weight is ideal for maintenance dosing. Fentanyl is an opioid. It's a major respiratory depressant. It is highly lipophilic but distributes mainly in the lean mass due to increased cardiac output. Hence, lean body weight is ideal for induction dosing. However, the relationship between the clearance of fentanyl and total body weight is not linear, but increases linearly with something called as pharmacokinetic mass, which mainly correlates with the lean mass. Hence, lean body weight or the adjusted body weight is ideal for maintenance dosing. Morphine, which is another opioid, is also a major respiratory and CVS depressant. It's highly lipophilic but distributes mainly to the lean mass due to increased cardiac output. Lean body weight is ideal for its induction dose. But however, not many studies on pharmacokinetic models are there for morphine. Hence, lean body weight or adjusted body weight is best correlated for maintenance dose. Remifentanil is a highly potent synthetic opioid with rapid offset and onset, has ester linkage in the composition. Remifentanil infusion simulations based on lean body weight showed similar plasma concentrations as in normal patients dosed to total body weight. However, total body weight based dosages showed higher plasma concentrations in obese. Hence, lean body weight is best. Remifentanil clearance is rapid and similar in both obese and non-obese. It is due to tissue and plasma non-specific esterases. Coming to inhalational agents, isoflurane, it's highly lipid soluble than sevoflurane and desflurane. But obesity has clinically insignificant effect on isoflurane uptake. Sevoflurane, it is less lipid soluble than isoflurane, however, resulting in faster recovery times than compared to isoflurane. But with increase in BMI, there is increased incidence of acute injury, acute kidney injury, and also possibility of nephrotoxicity with inorganic fluoride and compound A. Hence, it is advisable to use sevoflurane with caution in obese. Desflurane, it's least lipophilic and least lipid soluble volatile anesthetic. It is advocated for use in obese patients. Emergence is faster in both obese and non-obese. However, effect of BMI on desflurane uptake is not significant. Coming to the muscle relaxant succinylcholine, muscle relaxant of choice for intubation in obese patients. It is metabolized by plasma pseudocholinesterase, cholinesterases. Rapid onset favors rapid intubation and rapid offset favors return of spontaneous respiration. However, the pseudocholinesterase levels are increased in obesity. Hence, there is increase in the dose requirement. So that is why total body weight is used for dose calculations for choline. Vecuronium, it's an amino steroid with intermediate duration of action, but there is no change in volume of distribution in obese in spite of increases in the extracellular fluid. But recovery is prolonged likely due to impaired hepatic clearance. An overdose effect was seen when drug was given based on total body weight. Hence, ideal body weight dosing is ideal for vecuronium. Rocuronium is an amino steroid with an intermediate duration of action. It's weakly lipophilic, but there is no change in volume of distribution in obesity and clearance and elimination half-life compared to normal subjects, but there was prolonged recovery after total body weight based dosing. So hence ideal body weight is suggested for weight-based dosing. Atracurium, it's a benzyl isoquinolone with average duration of action of 30 to 40 minutes. Its use is advocated in compromised renal function. There is no change in the volume of distribution, but clearance is through organ-independent Hoffman's degradation. The duration of action is prolonged when dosed to total body weight. Hence, ideal body weight is suggested for weight-based dosing for atracurium. Neostigmine. Spontaneous recovery from non-depolarizing muscle relaxants in obesity is prolonged, leading to post-operative pulmonary complications. Hence, pharmacological reversal is very important. Neostigmine is an acetylcholinesterase inhibitor. There is no change in volume of distribution or clearance or elimination half-life in obese compared to normal subject. But in obese, neuromuscular function recovery even after full reversal with neostigmine is incomplete. Hence, ideal body weight is suggested for weight-based dosing in obesity for neostigmine. Sucamadex. It's a dextrin molecule with lipophilic core and a hydrophilic exterior. It has got more affinity to rocuronium than vecuronium, causes full and rapid reversal without any autonomic side effects as in neostigmine. There are not many studies on pharmacokinetic and dynamics effects of sucamadex, and also studies are conflicting with respect to dosing scalar. A study suggested ideal body weight, but recuriorization after sucamadex was seen in that study. Hence, total body weight is suggested for weight-based dosing for sucamadex. Coming to local anesthetics, lignocaine and bupivacaine. The effects of central uraxial blockade is unpredictable in obese due to physical effects of obesity on epidural space. But however, there is increased protein binding of alpha-1 acid glycoprotein, and therefore increasing the binding of the basic drug, that is the local anesthetics. Hence, their dose requirement is increased. Lean body weight is suggested for weight-based dosing for local anesthetics. So this is the comprehensive list of suggested anesthetic drugs dosing scalars for obese patients. Propofol induction dose, thiopentone, fentanyl, morphine, remifentanil, and local anesthetics should be given based upon lean body weight. Rocuronium, atracurium, neostigmine should be given according to ideal body weight, and propofol maintenance or TCI, succinylcholine, sucamadex, and midazolam to be given according to the total body weight. Conclusions. Anesthetizing obese individuals requires careful considerations regarding the changes in the pharmacokinetic and pharmacodynamic properties of numerous drugs used in anesthesia. Physiological and anthropometric changes such as increase in cardiac output, changes in the regional blood flow, and increases in the fat and lean mass affect the pharmacokinetic properties. In addition, respiratory pathophysiology such as increased incidence of obstructive sleep apnea, fat deposition around the oropharynx and chest wall alter the pharmacodynamic properties of anesthetics. Administering drugs based upon total body weight can result in an overdose, while administration based on ideal body weight can result in subtherapeutic dose. With the exception of the non-depolarizing muscle relaxants, where ideal body weight might be appropriate, lean body weight is the most appropriate dosing scalar for majority of the anesthetic drugs and opioids. Succinylcholine and sugammadex are dosed upon total body weight. These are my references. Thank you.